This patient, who had left-sided weakness, had complete resolution of symptoms by the time he reached the hospital. The MRI was normal. The CT angio, however, showed a proximal to mid-basilar occlusion. As the distal basilar was filling well through the PCOM and the patient was preserved, it was thought to be secondary to intracranial atherosclerotic disease. 7 hours later, patient developed left upper limb weakness of 3/5 and left lower limb weakness of 1/5. The repeat MRI shows patchy infarcts in the lower pons and the medulla. Therefore, mechanical thrombectomy was contemplated. The neuron max was taken coaxially over a microwire, microcatheter, and the aspiration catheter. Note the aspiration catheter being taken over an intermediate catheter up to the distal V3. The initial run shows a proximal basilar occlusion. Note the lateral view. There is an important clue to suggest that it could be a clot rather than intracranial atherosclerotic disease. Note contrast filling around the clot, and this is called as the claw sign, and it is a determinant of good reperfusion. The microcatheter is taken across the clot. Microcatheter injection shows patent distal basilar artery. Stent retriever being taken within the microcatheter. Then the aspiration catheter is navigated up to the clot. Following that, the stent retriever is deployed and the microcatheter removed. The aspiration catheter is further navigated to wedge against the clot and the whole system is removed. There was complete TK3 reperfusion and the patient did extremely well. Proximal basilar occlusions are generally thought to be intracranial atherosclerotic disease. However, a fibrinoid clot can get lodged at this segment and cause occlusion. The claw sign predicts chances of complete reperfusion, and it is important to monitor these patients very carefully.